Well, guys, welcome to Ivy League Learning numero 3. I like to be bilingual here, but I'm Judy Thompson. I'm the Director of Clinical Education with AVA, and we want to welcome you to today's session on Ivy League Learning, where we're going to talk about visualization technique for vascular access. So today we're going to talk about near infrared, but at the same time, if you have questions about anything that our presenters are talking about, this is not a CE event. You can ask almost anything and put it in the chat if you would. And at the end, Dr. Jacobs and I will go through and we'll feed the chat back to our presenters, and we'll hopefully come up with the answers for you guys. Down the road, we have more sessions that we're planning. So if there's something that you definitely want to hear, we definitely want to provide that speaker for you. So let us know, put that in the chat as well. And between myself and Dr. Jacobs, we'll go source a speaker for that for sure. I think we both have quite a few people that are in our little Rolodex. I'm dating myself by saying that, but but we can definitely go find speakers on topics that you're interested in, and we definitely want to do that for you. So I'm going to turn it over to my partner in crime for the Ivy League Learning, Dr. Kristen Jacobs, who is the chairperson of this series. Kristen, yours.
Thank you, Judy. We would like to welcome our guests this evening. We have Lisa Kaufman and Kevin Regan that are here to join us. Lisa is the Director of Sales for North and South America at Christie Medical, and she's been with Christie Medical for over 15 years, and she has experience with vein visualization in a multitude of clinical settings, including hospital, outpatient, oncology, and ambulatory and plasma donation centers. Lisa received her Bachelor's of Science degree in Industrial Management and her minor in Industrial Engineering from Purdue University. And Lisa currently resides near Tampa, Florida, which is near where I live. And Kevin Regan is the vascular access specialist for Bbraun Medical. And before that, he spent 8 years in emergency services as a paramedic, where he experienced the firsthand challenges of peripheral IV insertion. He received his Bachelor of Science degree from the University of Illinois, Chicago in biological sciences and specialized in bioinformatics. And Kevin currently resides in Chicago. So welcome, and thank you for joining us. I'll let you guys take it from here.
Thank you, Dr. Jacobs. I'm going to kick us off here. And thank you all for joining us this evening. Our topic tonight is using near infrared, your GPS navigation for peripheral IV insertion. How many of you use GPS to get from your home to the grocery store? How many of you use GPS to get somewhere you've never been before? We use GPS because it gives us the best route in fastest time and even reroutes us if there's a problem. It's construction, a road closed, an accident. It ultimately helps us avoid complications, which is exactly what near infrared can do as it relates to vascular access. We know how to start an IV. We know where to look for a vein, but near infrared helps us avoid complications that we can't see. So what do we know about near infrared after being in the market for over 15 years now? This is not a new technology. We know that near infrared has a lot of capabilities. It can provide more information to our clinicians, such as blood refill rate and valve location. It helps us to target the best vein, not just the easy vein. Near infrared can also confirm patency of the IV, and the evidence supports it. Many, many years of documented evidence with outcomes like significantly improved first stick success, coupled with longer IV dwell times. So not just getting the IV in for your shift, but having that IV dwell longer for the duration of the therapy. We also have near infrared evidence that states medically unnecessary PICC lines have been reduced as a result of better peripheral IV access. And it can contribute to long-term vessel preservation by alternating veins that are chosen for IVs and not using the same vessel that every clinician's using day in and day out. The evidence is there. We know that this technology is being adopted and implemented worldwide in acute care settings as well as non-acute clinical settings. Medical device companies have invested in new generations of product and are continuing to innovate and improve products based on feedback we get from the clinicians. There are 3 common technologies used for vein illumination for peripheral IV. Ultrasound visualizes vessels, arteries, and nerves. It can indicate the size and the depth of the vein, and it's considered to be the gold standard when placing IVs. However, this is a tool that requires a lot of training and a lot of practice to be really proficient at it. Transillumination uses a transilluminator, which is like a high-powered flashlight. The flashlight is placed on the patient's skin near the insertion site. Room lighting typically needs to be dimmed for the image to be a little bit clearer and brighter. We see that transilluminators are most often used in the pediatric and neonate population. And then near infrared projection. Near infrared is a harmless wavelength of light that gathers information from the blood under the skin and then projects a real-time digital image of the vessel right on top of the patient's skin, directly on top of the patient's skin. Different devices on the market may process that information differently. For example, some companies may use an LED projection system to project the image. Others may use a laser. Keep in mind, these are not competing technologies. They're actually complementary to each other. So it's possible that all of these technologies are being used in your facility by various clinicians. Using technology is not a sign of weakness. This is becoming the standard of care. It gives us more information, helps us to make a better decision, empowers us, and makes us quicker. The Infusion Nurses Society, INS, is an organization dedicated to setting the standards for best practices in vascular access procedures and maintenance. In the 10th edition of their infusion therapy standards of practice, published in 2021, January of 2021, Section 22.4 states, use near-infrared vein visualization for making more informed decisions. Near-infrared is referenced more than 15 times throughout this document. And statements such as use near-infrared during the assessment process to avoid bifurcations, valves, and tortuosity of veins. It also states that using near-infrared helps to decrease procedure time. So why? Why are we still making blind sticks when we have proven technology that can make our lives easier? A position paper published by AVA organization indicates that one stick should be the standard for vascular access. Is this the standard in your institution? I'm going to turn it over. Kevin's going to walk us through the next round of slides, and then we'll be available to answer any questions.
All right. Thank you, Lisa. And the last 2 slides on blind sticks and that position paper really had me thinking of my own experiences. Early on in my emergency department career, we did not visualize every vein before we stuck. And I know that I was often practicing blind. Before we go and look at the benefits of utilizing a near-infrared technology, let's look at how data supports our current practices. So we searched for reports in the past 25 years that looked at the average number of IV attempts per patient. And what we found is we have a long history of missed IV attempts, which brings us back to Lisa's question. Is one stick the standard? The data says no. Near-infrared technology is here to normalize vein visualization on every patient and eliminate blind sticks. And near-infrared technology is one that an entire hospital can embrace. It is quick to learn, and every single clinician can learn how to use it accurately within minutes. Unlike ultrasound, this does not require a specialized skill of inserting. Near-infrared technology is meant for the common clinician. Throughout the entire procedure, the clinician can keep their eyes on the patient and utilize their existing IV skills with the benefit of a true vascular assessment. And sure, you can always see a visible vein, but can you assess it? Oh, maybe I'm one ahead. Sorry. That's where I'm at. So, sure, you can always see a visible vein, but can you always assess it? As you can visualize in our embedded video, this is a perfectly straight vein, but at the very top of the image on this perfect vessel, we can visualize a bifurcation that you cannot see with the naked eye. And so to use Lisa's GPS analogy from earlier, even on a visible vein to the human eye, near-infrared technology can help make sure that you do not run into a traffic jam, like a bifurcation or a valve. This is a use that even nurses who prefer ultrasound-guided peripheral IVs can benefit from. And these better assessment skills will bring better clinical outcomes. Near-infrared technology is so important in the space of vein visualization, and that is why we continue to invest in this technology. We're making the technology even better for you clinicians, and some devices now even have advanced features to help you make the right gauge size decision. And this can be clinically impactful, as we know that the INS recommends that our catheters occupy no more than 33 to 45% of the vein. And another assessment skill that can impact better clinical outcomes is the ability to select the best peripheral IV length that a vein can accommodate. Near-infrared technology allows you to do a full assessment of each arm within seconds, allowing you to find the longest and straightest section to start your IV. And the recommendation is to get at least 2/3 length of catheter inside the vein. And by utilizing this knowledge, we can make the right choice of PIV length to achieve this and get our IV catheters dwelling into areas with healthier blood flow. And there are disparities in peripheral IV success that are relative to skin tones, and studies have continued to support this. Darker skin tones can make it more difficult to visualize the vasculature of a patient. Near-infrared devices are designed to highlight the vasculature of our patients regardless of skin tones and ultimately eliminate blind sticks. So using near-infrared technology can be done throughout the entire procedure. We talked about the pre-phase in depth by making quality assessment choices and the ability to find the best vein for better clinical outcomes. But during the actual insertion, you can also use the device. And you can use it to guide your IV placement and ensure that you do not blow through the vessel. And lastly, in the post-insertion phase, you can confirm the placement of your IV and check for the patency of the line. So we thank you all for attending this presentation, and we want to see clinical outcomes continue to improve through this learning platform that AVA has provided. And our keys to success are: be the champion for change. Work with your hospital education team to establish a policy to reflect the elimination of blind sticks. And as mentioned, this is a very simple device for us to train your staff on, and we can train entire hospitals on this device within days. And then understand your outcomes. Earlier, we looked at 4 studies that reflected that our patients on average are receiving multiple IV sticks per attempt. I hope the next study will reflect a change toward a 1-stick standard. Thank you.
That was great. Thank you. I loved it. So I actually, one of the slides you showed actually, I remember back in, I think 1997, something like that. It was 2.18 attempts to get an IV in, but it looked like your slide said that number was actually increasing, like 5.5, something crazy like that. That's frightening, honestly. What was it? Yeah, 1998, 1.18. In 2017, a 5.5 attempt, should be criminal, actually. But nonetheless, great presentation. Guys, if you don't use visualization at this point, if you're students out there, this is something I'm very hopeful we have some students in the crowd today, because this is something that is the future for you, for us, for our patients, for me as a patient. As I grow older, I definitely don't want a blind stick on me. I don't want you driving your car blind, and I certainly don't want you poking me blind. But so a question we have in from Catherine says, it looks like near-infrared versus ultrasound guided for pediatric patients may be easier since they move so much. Do most nurses find this? Second follow-up, they don't have near-infrared in their pediatric. They have sight-only ultrasound and a transilluminator. So one of you guys want to field that one?
I can start, and then either Stephanie or Kevin, you're clinical, you can jump in. I would say pediatrics is definitely one of the biggest users of our technology for that reason. First of all, it does visualize vessels, small, tiny vessels that, we can't easily palpate. And the devices that we have are hands-free, so it does allow for both hands to, be on the patient, maybe one nurse to hold the child and another to stick. And it's almost a distraction, sometimes the light, and if you're quick with it, I've seen it almost be enough of a distraction where you can get in before they really kind of know what's going on. But I'll leave Kevin, and I see Stephanie Pitts is with us as well, who worked in a children's hospital. Either of you can add color to that as well.
I think you said it very well. This device is fantastic in the pediatric population market. One, for the fact that it sees up to about 1 centimeter in depth. And I always kind of love the fact that that is a great sweet spot before you want to go into these more advanced procedures like ultrasound. This is a great way to do a full assessment of both your children's arms, both your pediatric patient's arms within, a much shorter time frame, and make that correct clinical assessment before you ever do a stick. So I love this device in the pediatric setting.
Perfect. Do we have any other questions from the crowd? You guys can open your mic up. You can ask directly to our presenters. I know.
Hello. It's
hello.
Sheila.
Sheila?
I heard.
Welcome.
Hi there. Yes. I had a question. I think I heard that you can. I saw that you could see hematoma detection with this device, but infiltrate as well.
Yes. So when you do a flush, so once you've started your IV and you do the flush, you'll be able to visualize that, either saline or medication move up through the vessel. Remember, the near infrared is reading the blood under the skin. So as we are diluting with contrast or saline or whatever it is, you'll see that move up through the vessel. In an infiltration, you would see that start to puddle outside the vein wall. So where you have a beautiful image of the vessel, a nice street, the video we saw, a nice big straight green line. If that's infiltrated, you would see that green start to puddle out. It would almost be like a little bubble around the vessel. So you can see the infiltration. Either when you're sticking, you would see if the vein's blowing, or even after the IV has been placed, you might see, if you're checking the patency of the IV, you might see that infiltration.
So is it more so when right after you start, or like I start an IV today and they're complaining about it the next day, would I be able to use this device to help with my assessment as well?
Yes, you're not going to be able to, so it's not going to read through where the dressing is, but my recommendation is typically that you would move the light to above to where the dressing is, to the vein. And same kind of concept, you're going to look for that push or fluid to kind of be fading the visual of the vein, fading that away as you're pushing. And if you're not seeing that, that's an indication that it's probably infiltrating lower. And then to answer your other question about the hematoma, I do love it for the reason, especially on darker skin patients, sometimes we can't see bruising as easily on the darker skin patients. So even from a stick yesterday or a couple of days ago, maybe it's an unsuccessful attempt that you can't see with the naked eye, you can see with the vein view or with vein illumination, because it will look like that same puddled, a vein that's been traumatized, so to speak. So you'll see that to avoid sticking below that point, right? So that you don't start an IV where it's, just had been infiltrated or a vein was blown. So we can certainly, show you in person at some point, but both of those are great questions, and both of those should be doable with this technology.
We have all three devices there. All three that you listed, we use them all on our PD patients there. So
Very good.
I'm very familiar with it, but that was the first time that I had heard that I could see it infiltrate with it. I never thought to use it that way. I appreciate that. Thank you.
Thanks for your question.
Mhm.
You talked briefly about the learning curve. I think, Kevin, you were mentioning the learning curve was pretty steep with ultrasound, which we know. And what's the learning curve for near infrared?
Yeah, so training this device with clinicians all the time, right? I mean, you pick it up, we show them how to use it. I would say a 20-minute in service, and they could adequately use it right after that. So it really comes into learning how to fine tune the device and using it so that you can maximize the accuracy portion of it. And then it's really about using your pre-existing IV skills. So we're not changing a lot of technique. We don't have to, hold an ultrasound probe, look over here and do the IV start. We're able to actually start an IV the way we know how to start an IV, but by using it for a better assessment.
The other thing, Judy, I wanted to talk about or, add to that is typically when we're training on new implementations or a new deployment, we talk about using the device on all patients, not just the toughest, the tough patients, right? Because it's just like any technology. The more you use it, the more your eye gets trained to what you're seeing, and your skill gets better with, sticking at, at the edge of the window there. But it's just as valuable to use the device early on, especially with all patients, even what we call easy patients, to get used to the technology.
Very good. We did get another question in about catheter to vein ratio. And I know it looked like you had some enhanced feature on being able to measure vessel versus catheter. Can you talk about that a little bit? Not the advanced feature as much, but also catheter vein ratio, or both.
Yeah, I mean, we know catheter to vein ratio is highly important. I can see, you're getting attacked by your animal too right now. My dog keeps running in here. So catheter to vein ratio, we know is highly important. It's about vessel health. It's about being, allowing for adequate flow around the catheter, and also for the infusion of what we're infusing. So with a new technology out there, we actually have the ability to place a shadow of each gauge size next to the vein that you're looking at. So you're able to actually measure off of your eye to actually see what a proper amount of catheter to each vein would be. And we know that through recommendations, we're looking for about 33 to 45%.
Perfect. So it's just a visual one-to-one. I look at my vessel and I say, oh, it looks like, now where you're pointing right now at a 16 gauge. And am I saying that's the size of a 16 gauge? And I'm guessing, is it about a third of the vessel size? I'm trying to interpret what you're showing me.
And this one might even be, potentially could be pointing to the 22 gauge on that vessel, showing that, that's, potentially a third of the size. I think it's really just showing you that you can roll that image right up against the vessel. And, this is clinician, the clinician, to Kevin's point, we still use our critical thinking skills and kind of our expertise and technique and all that. So this is really just more information about rolling that exact size of the gauge, image right up next to the vessel to give you the confidence that I can get a 20 gauge in there, or I really should, consider using a 22.
Beautiful. So Mark asked, does it detect possible vessel occlusion, i.e. clots, at least at a superficial level? And how would it do that?
I can't, I don't believe, I know it shows blood refill, which is, the refill of the vessel, but I can't say that it would detect clots or anything like that.
Perfect. Well, guys, I think if we don't have any other questions, this was perfect. This is exactly what we needed. So thank you so much. And again, folks, if you're on here and there are other topics you want to hear, we want to source those for you. Otherwise, it's Kristen and I getting on a Zoom call saying, what should we do? Who should we call?
I
So
think
Kristen and I
our
get a lot. What's that?
next one is on intraosseous, I think.
It is. I think we're doing one on interosseous. We've got some coming up on data, but we have a couple openings. I know I filled a couple recently. So guys, please give us the topics. We want to give you topics you want to hear, not just stuff that we want to hear, but hopefully what we want to hear, you want to hear. So with that, I know at some point, I'm going to bribe Dr. Pitts to come on. We're going to talk a little bit about some equity stuff, but that'll be down the road a little bit. But with that, guys, thank you so much. Bbraun and Christie Medical, thank you so much for supporting tonight. And we'll see you in 2 weeks for our next Ivy League Learning. Thanks, everybody.
Thank you, Judy.
Thank you.
Bye, guys. Bye.